as soon as I walked out the door, I had, all these questions, and so rather than, having to call into an office and get a question answered, I figured we'd open it wide open today for as many questions as you have. So whether you are a patient and have a question about symptoms and things, if you're in healthcare, if you're a case manager, or if you're a primary care provider, or whoever the audience is today, we're going to open things up wide open to any questions you have in a few minutes. I'm going to start with just some basics about spine. When it comes to the questions, just for health privacy and those things, we'd ask that you not go deeply into your own past medical history, or if you're already a patient, that you not necessarily discuss deeply procedures and things that you've had done just because of HIPAA violation reasons and protecting your personal privacy. So we're actually going to get started. I have what is actually a slide deck from a talk that I gave to a number of our own staff members earlier this year. I'm not going to go through every single slide. That's not the intent. I just have it here more as a reference than anything else. But I wanted to cover a couple of basics of spine before we kind of open up to questions. And I'll try to address some kind of common misconceptions and things like that. So we're going to just move forward here. This is actually one of the most important slides in the entire deck. So we're talking, we'll talk about the whole spine today if you have questions about the whole spine or about spinal nerves, because they run into the extremities and the legs and things. But most of the basics right here are just going to be about the lumbar spine to start with, because it's by far the most common. So you'll see some statistics there. Up to almost 6% of adults in the United States daily are having some variety of acute low back pain. That's an astronomical number. 6%, doesn't sound tremendous, but then you think about 300 million people, and that's an astronomical number of people who are having acute back pain on a day-to-day basis. Up to 70% of people will have some at some point in their life. Only about 30% or so will seek treatment for that. And the reason for that is the very next statistic, and that is, up to 60% of people recover within a week. So most of us, if we, pick up an injury, whether it's rolling our ankle or, smashing your thumb with a hammer or something like that, we'll do what most of us do, and that is kind of ignore it, take some Tylenol or ibuprofen over the counter, or put some ice on it, try and stretch it, just sort of move past it. And for up to 60% of people, that's enough for an acute episode of low back pain. And then you see, the rest of the stats that are there. The number that I usually use for folks, because it's easier than trying to memorize all these different things, and it's easier to think as a patient, is that when you have particularly like a disc and nerve related injury taking place, about 90% of people are better in about 90 days. That's kind of the general number that that's been demonstrated statistically, and this bears that out. This shows about 95% recovering within about 4 months. But up to 40% of people have a recurrence in 6 months. The question about that, well, why is that? It's because there's a lot of different things that can cause back pain. Just using the terminology, just basic terms of back pain, is kind of like saying head pain. Well, you can have a headache, or you can have a sinus infection, or you can have an ice pick sticking in your head. I mean, all of that is technically causing head pain. The lumbar spine actually is much more complex than many of the rest of the parts of the body as far as what can cause pain in that general zone. And so these things in studies all get kind of piled up into the same pile. So it's very challenging statistically to mince things out one way or the other. I just want to draw your attention to the center of the screen here. You see radiculitis, radiculopathy, very doctory language that's there. Anytime you see an itis, that means inflammation. And typically when you see an opathy, it means there's actually damage that's been done. That particularly radiculitis, radiculopathy is referring to inflammation versus damage of the spinal nerves as they exit the spine. So if you legitimately have what commonly is referred to as a pinched nerve, that's what that causes when you have pain, whether it's from the neck or from the low back that radiates outward and particularly down into one of the limbs. That's what we're talking about. The next line down from that has the word stenosis, and many of us have heard that in one place or another. All the term stenosis mean is you're taking an opening and you're narrowing that opening. So you can stenose a garden hose with your thumb across that. Some of you, for my patients, have probably heard me say that before. When you kink a garden hose completely, you have just stenosed it completely. So aortic stenosis is in the aorta here as it goes up from the heart, and when that's narrowed, that causes blood flow to have a harder time coming out into the aorta and get out to the body. Lumbar spinal stenosis is the same thing. It's that tightening of the canal in the low back, and that can be completely asymptomatic. It can cause pressure on nerves and cause an aching pain in the back, or it can cause pretty severe pain running to the legs, and things of that variety. Just the most basic concept of anatomy here. I'm going to try not to be too in the weeds with doctory terms and things like that, but the basic concepts. You have, the neck is made up of 7 cervical vertebrae. The rib cage attaches to 12 thoracic vertebrae. Then there are 5 lumbar vertebrae, which we commonly refer to as the low back. Below that is the sacrum, which is 5 vertebrae that are fused in utero. And then the bottom of that is the coccyx, which for the most part serves purpose only to be a frustration and to cause discomfort. I don't want to get too far into a lot of these different things here. The basic concept, if you look at those 3 pictures we have there, this one right here, which this is a model representation of what the spine looks like. So this is the front of the spinal column itself. These gray guys are intervertebral discs in between the vertebrae. The openings here, where you see the little yellow line coming out, that's a representation of a spinal nerve coming out of that open space here on would be the left side of the spine, and there would be an identical appearance on the opposite side. And then behind that, you can see the spinous processes, which are the little bumps that are there. On small enough and slender enough people, you can see the individual spinous processes just going right up the back of the spine. And those truly don't cause any symptoms at all, except when they're inflamed from being pressed or rubbed out over top, or on the rare occasions that they fracture. The posterior elements here, the facet joints, are a significant cause of back pain, a very frequent cause of back pain. I refer to them kind of as the knuckles of the spine. Then that is, you don't even know that they're there until they're causing you trouble for the most part. There are small nerve branches that go to the facet joints. They're called medial nerve branches, and they run off of a larger spinal nerve, and then one part of that nerve goes to a joint above and one part to a joint below, and that's how your brain finds out that there's pain in those joints. The epidural space, so you hear the word epidural, people are like, oh, I had an epidural. That's actually kind of a slang term. The epidural space is the space between the covering of the spinal cord and spinal nerves and the extreme outside of the spinal canal itself, between the edges there, and that space is the epidural space. And so when you're having anesthesia for surgery or for having a baby or something like that, you dump numbing medicine into that epidural space. When we're doing like an epidural steroid injection, of which I do many, the goal there is actually to put some steroid, which is a high-powered anti-inflammatory, onto the spinal nerves, and then also into that epidural space to hopefully reduce inflammation and calm things down. So I'm going to encourage you, if you have questions that you'd like to type into the chat box, feel free to start typing those in. If you have a question and want to unmute yourself and ask the question, that's perfectly fine. I have a couple of questions that were sent in already that I'm going to just start addressing one of those. So if you have questions, feel free to put those in there. First question I have is I have degenerative disc disease. What can I do about it? So let's start with that term, degenerative disc disease. The discs of the spine, for the most part, in every human being, degenerate over time, just like the tires on your vehicle wear down. There are some folks genetically who will have more degeneration than others, or earlier degeneration than others. And in some situations, there can be some wear and tear that drive worsening degeneration. But probably the real problem we have with that term is the word disease. It makes it sound like it's an infectious process or something like that. In most cases, it's just normal wear and tear on those discs, which are designed to be shock absorbers. Their whole job is, and we'll go back to that picture that I showed you a second ago, their whole job is taking the shock of the bones, being bounced up and down, or the muscles pulling and tugging on those things. And as they degenerate over time, sometimes they cause pain. Many times they do not. So just because a disc is degenerated doesn't mean that it's a painful condition. you can develop some pain from those. Now, the second part of that question, what can I do about it, is actually a great question. I was discussing this with Sloan a few minutes ago. If and for any of you that are patients of mine already that have been in to see me in the office or been in to see Kelly Cunningham, my PA, you more likely than not have had a conversation with us about exercise. It is tremendously undervalued in the medical community, the idea of regular exercise. Excuse me, I'm sorry, something popped up there. It's tremendously undervalued. The best thing that you can possibly do for trying to protect yourself against degenerative disc disease or against the problems that can come from that, like spinal stenosis or facet joint pain or things like that, is actually full body range of motion exercise. So a lot of us, when we're having pain, it's hard to do much exercise. I don't ever suggest for folks to go out and just run for miles or walk for hours. If you have stenosis, you can't do that very effectively at all. And so the best thing that you can do is good full body range of motion exercise. Sometimes that means getting into a pool and doing, pool exercises, because you can take the weight off and you don't have as much weight bearing on your joints and things like that. Sometimes it's something like yoga or Tai Chi. And so the biggest challenge is trying to find what fits you best. But in anything that you can do where you're moving your whole body as much as possible, is the best thing to do. For younger folks that can handle higher impact, then high intensity training is a great thing. You don't have to do CrossFit, but something that's high intensity training is good. I'm not a big fan of heavy weightlifting for most people, except for athletes, because the heavier you're lifting, the more likely you are to injure something, and then we have more problems. So one of the patients has asked the question or made the statement, I have stenosis and the pressure on my back is bad. I cannot walk far without slumping and increased pain. This is what stenosis does. So stenosis, as you narrow the spinal canal, it's just like I said, it's kind of like kinking the hose. And the more you straighten up, whether standing or sometimes even just laying flat is enough for some patients to have symptoms. That's, the more you kink the hose off. And the only way to take pressure off of that is to unkink the hose. And so it's a natural mechanism is to lean forward and take pressure off of the spinal canal. I oftentimes, as we're going through a course of treatment with patients, will suggest that they utilize a rolling walker when we're first getting started with trying to get moving more, because it allows you to bend forward. You get some counterbalance from your hands on the rolling walker and takes pressure off of those spinal nerves. Another question, and this one's a real challenge that we run into, especially in this area. I have a patient that asked about serious tailbone pain that flares up with long periods of sitting. So the tailbone itself, the coccyx I mentioned previously, is one of those things that it doesn't have a tremendous function. It has a few ligaments that wrap around it, and sometimes you can get pain from those ligaments being too tight. It absolutely is easily damaged with hard falls, or certainly sometimes during childbirth or things like that, and the coccyx can flare. It's actually one of the hardest things to treat in spine, because we can't go through life and never sit down. It's that's very challenging. I've had patients that just lost some weight and so had less padding on their backside and developed significant coccydynia. That's the medical term for it. But when the tailbone is flaring, there actually are very few people even around here in East Tennessee who are willing to see you to discuss it, because it's so hard to treat. Physical therapy can be helpful with strengthening the glute muscles and with changing, kind of helping to learn to change the way that you sit. My partner, Dr. Lavelle and Dr. McGurk, do what's called a ganglion impart block, which is a type of injection that can be done to soothe the inflammation taking place on the coccyx. It's pretty effective. There was a time where physicians would remove the coccyx when it was repetitively painful, but they found that at least 50% of people who had them removed still had the exact same pain there. That really brings me to a very important concept when it comes to spine, and that is, if you don't have the diagnosis right, the odds of your treatment working are basically down to placebo effect. Now, the placebo effect can be quite strong. It can be up to 30 or 35% of the value of any intervention. But if you're diagnosing the wrong thing, or if what you think is causing the pain or what you're treating for is not the actual cause of the symptoms, your odds of being effective are very, very low. And that's kind of common sense, it sounds like. But unfortunately, a lot of people, in spine medicine don't take the time that it takes to figure out exactly what's taking place. And sometimes that's a training issue, and sometimes it's just a velocity problem, just moving too fast and assuming that something is being caused by one thing or another because it kind of sounds like it. I will tell you, I have many, many people that come in regularly and have similar sounding stories, pain in the back, pain into the leg. If you just assume that every single one of those is a disc herniation or stenosis, you're going to miss a ton of situations that are pretty complex. So I have a question from one of our physical therapists at Select in Tellico Village. Andy asked to discuss the effect of appropriate types of core training on functional stenosis. So the word functional there is the important word. You can have stenosis that doesn't look bad on an MRI because you're laying, but when you stand, that's how I take standing x-rays of every patient. You can have a completely different posture when you're standing than when you're laying down. And you can actually have a much more narrowed spinal canal when you're standing than it looks like you should from a laying down MRI. Now, the value there, and any of you that are therapists that have had orders from me, if I have patients that have stenosis, or if they have a spondylolisthesis, or have a lot of facet joint pain, what you're going to see from me is flexion-based exercises. And that's all about strengthening the low abdominal pelvic core. So kind of classic sit-ups and crunches really more work the upper portion of your abdomen and your abdominal muscles, than the lower part. And that's fine. It particularly is helpful for wearing a bathing suit, but it doesn't actually help with back pain significantly. Working the lower abdominal pelvic core is the most important. And so I frequently will counsel patients, needing to do things like reverse crunches, which is more bringing the knees to the chest, and doing pelvic tilts. And there's a lot of different types of exercises that can be used to strengthen the low abdominal pelvic core, but it does several different things. So firstly, it increases the tone of those muscles at rest, so you don't have to think about it. They're protecting you to begin with just because the tone is better. It also teaches you as a patient to work those muscles. And when you first start, sometimes they're really sore afterwards because you haven't worked those in a long time. But it teaches you as a patient to work those. And so you can learn how to turn those on even when you're standing. Standing with pain from stenosis, just doing a pelvic tilt sometimes is enough to help to reduce some of that pressure and improve the symptoms that are there. So abdominal core strengthening is absolutely vital in treating low back pain. And in fact, if you're not doing enough of that, you're going to have a hard time getting any kind of long-term relief from anything else that you do, whether it's a modality, like traction or things like that, or even the injections and things like that that can be done for these things. You're going to have a hard time having long-term relief if you're not doing good core strengthening. So it's tremendously important. And to be honest, it's really simple. It is not, it's not something where you have to reinvent the wheel with every single patient that walks in. Functional core strengthening is, I cannot highlight enough how important that is. So thank you for that question, Andy. I hope that answered your question. I had a question here about whether weight loss helps with stenosis. I'm going to generalize that just to back pain in general, and then the answer is the same for really all generalized back pain, and that is I've never seen a study that demonstrates that weight loss, even significant weight loss, has a tremendous impact on low back pain. As far as its effect on discs and the spinal canal, I've definitely never seen a study that shows that losing, say, 15 or 20 pounds makes any difference whatsoever for a case of stenosis where the spinal canal is narrowed. What does help, and this is why I talk with patients, they'll hear me say, I don't care what the scale says, and I don't care what shape you are. I care how strong you are. That goes back to the initial point about needing to be exercising regularly. I have a lot of folks who say, well, I go out and I walk, but my back starts to hurt more when I'm walking. And that's absolutely true. The longer you're in that upright position, going in one direction, moving your muscles the same way, you're going to get sore. And that doesn't actually help strengthen your core. It doesn't do much it doesn't do anything for your upper half of your body. And it doesn't do a lot for your legs and wide range of motion and things like that. What really is much more necessary is to strengthen the muscles around the middle. So those low back muscles, those abdominal core muscles, and then the muscles that run your hips. and the buttocks, like those need to be strong in order to be able to protect the low back and keep it from having much pain. So I again tell patients all the time, I don't really care what the scale says. As far as back pain is concerned, I do care, that people be healthy. I care that you be in good shape. I care that your blood pressure is in good condition. I care that you not smoke. Those things only tangentially affect your back pain and things like that. With the one caveat, smoking actually significantly increases degenerative disc disease. There have been some very good studies that have demonstrated that. So if you are a smoker who struggled for a long time, I encourage you try to quit, because it's affecting more than just your blood pressure or risk for cancer, something like that. But back to the exercise issue, losing 10 or 15 pounds, the best thing that does for you is give you more ability to move in different directions. It probably won't just radically dissipate your back pain significantly. Next question I have, how often would you say that you see patients with low back pain that have previously been misdiagnosed, or even the patient's lumbar anatomical problem being completely missed altogether? The answer to this is every day. Every single day I see patients. Now my practice, being that I work in an orthopedic surgery group, is I frequently see people who've already had spine surgery somewhere else. I frequently see patients that have, issues that are potentially complex, and really, maybe they feel pain in what they feel like is their hip. And so they've seen one of my hip partners and they take a look and say, gosh, your hip x-rays look great and there's nothing there. Well, go see Dr. Yoakum and he can figure out what actually is going on. Maybe it's from your spine. And sometimes it is and sometimes it isn't. I also often see patients who have seen 2 or 3 other providers around the area. And sometimes, it just takes a fresh set of eyes. I would imagine there probably have been patients that I have seen that I've had a hard time figuring out what's going on, and they saw somebody else with a fresh set of eyes that came to it and they were able to find it, or figure out what somehow I was missing. But for the most part, what I see are people are just moving too fast. You say, I have pain in my back and my leg, and they say, oh, it must be a disc issue. And so they do whatever's required to get you to be able to have an MRI, get the MRI and say, hey, there's a disc herniation in this spot. And that's probably what it is. So let's do an injection, or let's do a surgery, or let's do whatever. But never really tied together the history of what the symptoms are, tried to reproduce the symptoms with physical exam. If you've been in to see me ever, most of the time, I'm going to try and reproduce those symptoms so that I can be confident at what the problem is. And then thirdly, you have to have the right treatment for that area. So, for instance, epidural steroid injections in the best studies only demonstrate about 60% effectiveness. But the problem with that is there's such a wide range of what's accepted as diagnostic criteria that you can't be sure that people are getting the right thing for the right problem. So unfortunately, I very frequently see people who what is going on has been missed. Or the other thing that happens, and this happens even more frequently, most people, if you've had some kind of back pain or neck pain for more than 2 or 3 weeks, by then you probably have multiple things taking place. And so I'm actually going to scroll through some of the pictures here and move forward to a couple other things. Let's see if I can get a good spine shot. Nope, that was Arnold Schwarzenegger. All right, I'm going to go back. I apologize for the pause there. Have we all not had enough Zoom calls for the year already, right? All right, so just the basic concepts of the anatomy. There we go, that's the picture that I wanted. Just looking here at the lumbar spine are these 5 vertebrae. This is, we're at an angle looking at this. It's not a dead-on shot, but this is the pelvic bone right here. It's called the ilium. All the way down here is where your hip bone, it comes and attaches onto the pelvic bone, which is right there. So the actual hip joint itself is much lower than most of us feel like it is. This is a representation of the sacrum right there. And then the iliac bone comes right next to the sacrum. That makes the sacroiliac joint. You can see the L4-5 and L5-S1 facet joints, and then obviously the discs and those things. There are, in this region here, which is basically about your belt line, with an inch or 2 above, an inch or 2 below, there are 5 or 6 different potential causes of pain in that area. If you add to that the fact that you have some pain in your leg somewhere, it sometimes makes a very cloudy picture. And so, the idea of just having a singular problem with a singular solution is actually pretty rare. I found in my practice, a lot of times people will have multiple issues taking place at once. And so again, it's exceedingly important to be able to identify what are all of the players at hand. what symptoms that you have are coming from which problem. And then we make our expectations such that, okay, we're treating specifically your sacroiliac joint pain, for instance, but there may be some irritation from the L5 nerve that's underlying. You've got some deconditioning of the gluteus medius muscles. Like, we need to know what we're doing with what specifically we're trying to treat to help our expectations be correct. So if you've got 3 problems taking place and we start treatment with therapy and perhaps a targeted injection and remove one of those so that it's basically gone, but there's still 2 left. Okay, we're partway there. It's, we're not done, but we're partway there. And so trying to manage those expectations specifically and help to understand what are we actually looking for is very important. Next question is a spectacular one. What's the difference between a ruptured disc, a leaking disc, a bulging disc? You can add on to that terms like blown, slipped. There are a million, not a million, there are a lot of slang terms when it comes to discs. And the reality is, it doesn't matter what the disc looks like. If it's not causing pressure on a nerve, or if it's not inflamed, then the disc probably isn't causing the symptoms. So technically speaking, the disc itself can bulge. It has let me find a picture of that. There's a thick, there we go, that's it right there. So if you look at the blue, this is the inner core of a disc right here. Again, it's a representation of those. And this is the outer edge called the annulus fibrosus. It's very thick and tough. It's just kind of like if you've ever had a steak that has one of those round pieces of cartilage that's in there. That's about how tough these things are. They're very tough. So that disc itself can bulge somewhat and push out, and so the term bulging disc is there, or it can be completely torn, which is an annular tear, and allowing some of the inner part, which is called the nucleus pulposus, to herniate out. So those are the 2 possibilities. Or the disc itself can bulge somewhat while the material stays inside, or it can actually rupture and disc material can come out of there. It's really just 2 options. All the rest of the terms, slipped, or all those kind of things, are really just kind of generic. There's slang terms that have come about that don't have a specific meaning to them. So then the question is, well, what do those different conditions cause? If the disc is only bulging, so I can find that other picture I had for you. There we go. This is a great one. So if you look here on this here on the right side, you can see this orange highlighted material. That's highlighting of a broad-based disc bulge that's taken place. It narrows over here a little bit, or one of the nerves runs by, but you see all these black nerves that are in there. None of them are touching that disc. A disc bulge like that is rare to cause any kind of symptoms whatsoever. If we drop down to the blue picture here, you can see the edge, so we have the edge of the annulus fibrosus is now, you can't even see it anymore. All you see is this blue material pushing out. So this is representing a disc rupture, where the disc material is pushing out from inside, but it also is contacting the nerve root as it runs past. That's this blue representation here. This would be expected to cause likely some pain in the low back, but significantly so, pain radiating out toward a hip or a leg because it's contacting that nerve root. This actually is a thoracic vertebra, or excuse me, a cervical vertebra that's being shown here. So it would be the neck and the arm as opposed to the low back and the leg, but the concept is the same. We come up to this next one, you can see this disc protrusion pushing out is contacting the nerve that runs past. And then by nature of the fact that it has completely blocked off where this nerve is coming from, you can see pressure on the nerve there. That would be 2 different levels where you would have likely nerve pain coming from. And so it wouldn't just be pain in the low back radiating down the back of the leg, for instance. It would probably be the side of the leg and the back of the leg. And so identifying which levels are taking place or which ones are causing the symptoms is the number one goal. If you don't identify correctly where things are coming from, you can't possibly be successful. Then you're just hoping that time is enough to fix things. And going back to that earlier question about, how often are people misdiagnosed? The best answer is far too often. Far too often, folks are not listened to well enough, or aren't helped to explain what's going on. That's one of those barriers as a physician. We all have training. We have a lot of very specific clinical terms that we utilize as we're discussing things with physicians. I try really hard when I'm discussing things with patients to try not to be terribly technical and clinical. It doesn't do you any good for me to spout a bunch of words that you don't know what they mean. And that's not about ignorance. It's about education. It's about training and experience. I'm supposed to know what those things are. You shouldn't have to. So the goal every time that we see folks is try and figure out what's going on, and sometimes that means me helping a patient, supplying words for them or helping them to describe or discuss what's taking place, so we can kind of parse out the fine details of, okay, so you have pain in your back and hip and leg. Is it a hip joint problem, an iliotibial band problem, and low back arthritis, or is it what most people would jump to, and that is a situation like this with a disc herniation putting pressure on nerves? I had a question also that was sent in earlier that I wanted to get to, that was, why is back surgery so bad? And why is it so dangerous? Great question. I was really pleased that one came in, because it's one that I actually have conversation with patients a decent amount of the time. Statistically speaking, about 10% of patients that present to a spine physician probably need surgery, about 10%. In the United States, surgery is performed at almost double that rate. So almost 20% of people who see a spine surgeon have surgery. And there's some different reasons for that. Some of it is physicians moving too fast. Some of it's a training problem. Some of it is, if you're looking at something and it's not attractive, there's an ugly disc bulge on the MRI, and but the symptoms are on the opposite side or at a different level, but it's still there. You try and treat things, it doesn't get better. If you keep going back to a surgeon, eventually they're probably going to operate on you, because that's what they do. It's the tool that they have. It's not saying that the surgery is bad. In fact, spine surgery is spectacular when it's appropriately utilized. Is the best way to answer that question. The reason that there are so many people who have pain still after having surgery is often that the diagnosis just wasn't complete. Sometimes it's even partly correct that there was disc herniation or stenosis causing symptoms. You do the appropriate surgery for those things. You go through an appropriate recovery period for inflammation to drop down, and there's still some back pain or still some leg pain. Well, a lot of times it's because it was a nuanced diagnosis. There were multiple things that were problematic. And so whenever I have patients who I'm sending to a spine surgeon because they need surgery, and that's about 3 to 5% of my patients, I always prep them for, listen, there's a lot of things that can cause pain in your back. I've already, so we've been going through a treatment plan. We've already found a couple of things that are causing some of your symptoms. The biggest problem you have that's not going to go without surgery is the nerve compression taking place from this disc herniation or stenosis or whatever. But after surgery, if you're still having some back pain, or if things aren't just perfect and amazing, come back and we'll treat what's left. So if you've had the right thing fixed. The statistics tell us that doing back surgery for back pain only is 50% effective. Now, the way that sounds is, back surgery is only 50% effective. That's not true. That's not what that statistic means. What that statistic means is, if you don't have the right diagnosis, your treatment's probably going to fail. So 50% of the time when spine surgery is performed for spine-only pain, 50% of the time, the diagnosis is right. The stenosis that's there is causing the pain, or the disc pressure that's there is causing the symptoms. 50% of the time, the diagnosis is wrong and wasn't gotten correct in the first place. It's joint-related pain or muscle-related pain or hip-related pain, or something like that. So the reality is, spine surgery is not a bad thing. In fact, it's an exceptional thing when it's necessary. I want to show you a picture here, and I intended to get another. Let me see if I can find my spondylolisthesis. There we go. So this picture right here, it's a little graphic looking. It's from an older anatomy textbook. But this is the L5 vertebra as it's relating to the sacrum. And this here you can see is a facet joint. This is a depiction of what's called a spondylolisthesis. So the vertebra, where it's supposed to be attached here, you can see it's fractured through. That's what's showing this red here on those ends. Those are the edges of a fracture zone that's fractured across through, and that allows the vertebra to slide forward. I don't think I have another picture. Nope. That allows the vertebra to slide forward. And when that happens, oftentimes you uncover the disc and it creates a large herniation. You significantly narrow the neuroforamen where those nerves that stick out can cause all kinds of pain, either just in the back or radiating to the hips and the legs. I have one of these in my back. I have a huge spondylolisthesis. It's a grade 2, it's borderline grade 3, which is, getting to the point where there's no room for the nerves from my L5S1, my L5 nerves have almost no space to get out of the L5S1 neuroforamen. I have a massive disc herniation in that. So it's enormous. It's a bigger disc herniation than I probably see on a monthly basis. And I look at thousands of MRIs every year. It's huge. I have had times in the past where I had back pain. I know at some point it may progress to the point that I'll have to have surgery for it potentially. But what do I treat it with right now? I don't take any medicine. I've never had to have one of my own injections. I had them practiced on me in residency because it's what you do as a resident to learn things, but never with the actual medicine or anything like that, just the placements. I exercise. I'm a big guy. I carry, a fair amount of weight, and I exercise high intensity interval training 3 or 4 times a week for about 45 minutes. And I haven't had legitimate back pain in years. So exercise really, truly can make that big of a difference if you're doing enough of the right stuff. I just want to look and see if there's other questions here. I feel like y'all have been listening to me go for a while. If you have a question you want to unmute yourself and ask, you're more than welcome to. All right, let's see. I think I have 1 or 2 more questions here, and then we'll probably start winding down in the next 5 minutes. This is my favorite. So someone sent in and asked, what is sciatica and why does the sciatic nerve cause so much trouble? The sciatic nerve gets a bad rap. The sciatic nerve itself is not actually in the low back. It comes together in the low pelvis heading into the back of the thigh. It's made up of several nerve roots. The most useful innervation in there are the L5 and S1 nerve roots, but it actually comes together in deep in the pelvis, not in the low back, and it runs down the back of the thigh. Now, the term sciatica is kind of a generic term that's been around for a long time that means pain somewhere in your back and running somehow into your leg. There's a lot of things that can cause that. The sacroiliac joint can cause symptoms that are more kind of low back to buttock and radiate down into the posterior leg. I've had patients with sacroiliac joint pain that felt it, they perceived it in the front, like near the groin, because it's part of the pelvis. The hip joint itself can cause what some people would describe as sciatica. The nerves in the coming out of the spine, the L5 or S1 nerve roots, if they're pressed on by a disc, can cause what some people would refer to as sciatica. So you'll never hear me diagnose someone with sciatica or with a sciatic nerve problem, except for the rare cases where they actually have damage to the sciatic nerve itself, which usually takes falling and landing hard on your buttock and getting a contusion of that nerve. So the reality is we use the term sciatic nerve a whole lot, and most of the time it's actually incorrect. It's not often the sciatic nerve actually is involved. Usually it's one of the nerve roots that go to that nerve, like the L5 or the S1 nerve roots, or sometimes, as I mentioned, it's a joint that's causing symptoms in that area. So that was a really good question. It's one that I try really hard to try and help folks understand, what's going on. The last one I wanted to address, and if you still have a question, feel free to ask it there. The last thing I wanted to address is I will, on a very, very frequent basis, have patients come in and say, I have a cousin or a friend, or was talking with, with one of my husband's coworkers or whatever, and they have the exact same thing that I have. And here's what they did to treat that, and can we try that? I never have a problem with folks saying that. The reality is every single person I see is different. Everyone is unique. The odds that you have the identical problem somebody else does are exceedingly small. The truth is we just have very limited vocabulary in our normal daily discourse to describe what's going on between our rib cage and our pelvic bone. So it all kind of turns into I've got pain in my back that runs into my hip or my leg, or stays right there in the back or whatever. And so with the really limited descriptions that we utilize in our normal conversation, it makes it sound like you talk to people and they must have the exact same thing that I have. The reality is every person, in the lumbar spine especially, is so complex. that you really have to be able to parse through the different pieces of what's going on. It's very rare to have two people back to back that truly have identical problems. Do I run into, since I see, this stuff all day long, do I run into folks in a given week, for instance, where I have a couple people who basically have the same problem? Sure, I do. And so it's possible, which is why I never give people a hard time if they say, hey, so I talked, this person has exactly the same thing I do. And then they tell me the treatment, and it's actually for a different problem than they have. So we just talk about it. So I just go through and say, oh, you heard about a radiofrequency ablation. That's a great treatment for pain coming from the joints in your spine. It won't change your spinal stenosis, though. And so doing that, nerve cauterizing procedure wouldn't change the symptoms that you have, because yours is a little different, even though it feels a lot like the same description. That's just kind of one of those things, but with our limited vocabulary, we end up, having things sound like they are pretty much the same. Well, I haven't seen any more questions come on. If anybody has one, this is your chance.
While we're waiting on the last few questions, Dr. Yoakum, I just wanted to thank everybody for coming. I put a little bit of information in the chat box about scheduling with Dr. Yoakum, and also that we will be sending out a follow-up email that has this whole presentation recorded just for your reference, or you can share with your friends and family. It will be on our YouTube channel as well, and also on our Facebook. So if you would like to view it there as well, we will have it there as well. Oh, I just saw another. Just thanking Dr. Yoakum. Yes, Dr. Yoakum did a great job today. He's one of my favorites. So thank you guys so much. Unless there are any final questions, we will wrap up for the day. And if you go to bed at night and you're like, oh, I should have asked that, just send us a email to either the RSVP email or the feedback email, and I'll shoot that over to Dr. Yoakum, and I'm sure he'll be happy to get you an answer.
There's one last question that was asked, and it's a good question. The question is, as an orthopedist, do you focus more on the bones of the spine, or do you give detail to the nerves? And so the reality is, my training is my specialty is physical medicine and rehabilitation, and which is the most broad specialty there is in medicine. You do training in traumatic brain injury and spinal cord injuries, and small local nerve injuries. You do an electronic diagnostic studies and things like that. Now, my job, what I do on a daily basis, is largely orthopedic in nature as far as evaluating spine and joint. But yeah, the answer is all of the above. If you're not thinking about the muscles and the soft tissue and the fascia and the nerves that could be involved, and the bones and the joints and the discs, I mean, you've got to consider all of it. If you don't, you're going to miss a lot. You're going to miss on a lot of patients, and you're going to have folks who keep suffering, who keep having issues that aren't getting better. So good question. It is a little bit of everything is the answer to that question.
Dr. Yoakum.
Yes, ma'am.
I wanted to thank you too. You helped me over a year ago. I had 3 injections and was actually scheduled for back surgery. And then the third one kicked in, or either I was terrified of surgery, but you did help me, and I love you to death. And thank you so much. I was very anxious to watch your presentation. So thank you.
Well, good. I'm glad you got better. It's one of those things in the national discussion. We often talk about statistics, but the hard thing sometimes in training physicians is getting them to understand that each one of those statistics is actually a person. So I'm glad that you did so much better and didn't have to end up having surgery. That's great.
So am I, and I give you all the credit.
Well, I wouldn't give it to me. I mean, I'm sure that I had a part to play, but thank you very much for sharing.
Thank you.
You're very welcome. All right. Well, thanks y'all for joining us today. I'm sure there'll be more hot topics coming up. I don't know that anybody else will do just a question and answer session, but this was really effective, I think, and I hope you guys had a really good time.
Yes. Thank you so much, Dr. Yoakum. Everyone have a great day.
Thank you.